second session of Arsha seminar. The today's speaker is Dr. Pragnya Rajesh Kapse madam. She is MS Ayurveda as well as PhD scholar from Pune University. She had done so many various courses like diploma in cosmetic acupressure, diploma in Sanskrit, MS psychology, and yoga and everything. So madam is full of knowledge in many subjects. Along with that, she is teaching for more than 12 years in a reputed college, that is R.A. Poddar Ayurvedic Medical College, as an assistant professor in surgery. So, she worked with various television channels like Sam Marathi, DD Sahyadri, ABP Maja, working with Vedraj Supraja Mission and various Ayurveda magazine as an Ayurveda expert. She has her live interview on topics like fissure in ano, piles, fistula, backache, etc. And she presented various case studies like role of local application of Yashti Madhu Malhar in acute fissure in ano, as well as prevalence of obesity among young female college students. She has participated in World Congress on Ayurveda Pondicherry, World Congress Ayurveda Calcutta, Gujarat, as well as World Ayush Expo. So she has received awards like Himalaya Ayurveda Award winner, Sir J. Tata Scholarship winner, Scholarship Award, Kamal Bhushan Award by Ayush Maharashtra State. And mainly she is so thorough in her knowledge as well as she is very good at teaching. So we will see in next few hours that she can deliver very good lecture, the complicated lecture like on defecation. She can deliver very good talk. So without wasting much of your time, I would request Pragnya Kapse madam to deliver her talk on physiology of defecation. Thank you madam. We welcome you all.
Thank you, Dr. Rushikesh. Thank you, the whole team of Shreyas E-Learning Academy, my good friend Dr. Mangesh Deshpande and his all colleagues. I am very much thankful to all of you for giving me the opportunity to share my views on the topic, which is very, what we can say, delighting topic in this era, that is defecation process. So, without wasting time, we will start the presentation. But I would have been glad if it would be an interactive session and you all were in front of me. So, but it's okay. We can interact in this online session also. See, basically, defecation. What is defecation? That we will see. It is a final act of digestion. So all of you can see this diagram. So basically it is closely related with the anal canal and rectum. Means whenever we say that any entity or any disease related or any pathology related to defecation, that means the structure in the digestive system that is comprised of this involvement of pathology of defecation is nothing but the anal canal and rectum. So it is mandatory that you should know the anatomy, and you must have learned in yesterday's lecture delivered by Dr. Rushikesh. I assume that all of you know the anatomy of anal canal and rectum, but in a brief introduction or as a revision, we will see that this is a rectum. This is pinkish, having pinkish mucosa. Then it is having 3 folds, okay, haustrations we can say. It is also having the vertical columns, you can see here, that is anal columns of Morgagni. and the imaginary line which is comprised of the dead ends of these columns, it is called pectinate line or dentate line. Now it is having two sphincters. We know one is internal sphincter. See, this is internal sphincter and this is external sphincter. So this is a coronal section of anal canal and rectum. Here in between you can see the anal crypts where the anal glands are situated, and the infection of these anal glands, it ultimately causes the formation of fissure, anorectal abscesses, fistula, piles. Any infective pathology can occur at this level. And basically it is squamo-columnar junction. The junction of anal canal and rectum, it is comprised of or made up of squamous and columnar tissue. Basically, surgical anal canal, what we say or what we deal with in our day-to-day practice, is of 4.5 centimeter, 10 centimeter or 4.5 angul, we can say, in length. And basically external anal sphincter and internal anal sphincter, these are the two most important factors or anatomical structures in this anal canal which are important for the process of defecation. Now we know that the nerve supply for this gastrointestinal tract or digestive system, it is of two types. One is intrinsic nerve supply and another is extrinsic nerve supply. So intrinsic is related with the presence of the wall of GI tract from esophagus to anus, and intrinsic nerve supply is comprised of autonomous nervous system. Now intrinsic that is related with enteric nervous system, it is having Orbeck's plexus or myenteric plexus in it, which regulates the movement of GI tract, gastrointestinal tract. And it is having inner circular and longitudinal muscle. So longitudinal and circular muscles, these are having main action or role in the process of defecation. So nerve supply is very, very important to know. Meissner plexus or submucosal plexus, it regulates the secretory function of GI tract, and it is having muscular and submuscular layer. That is, we can say submuscular layer of mucosa. So it is very important to know this. See, this is the diagrammatic representation. Orbeck's plexus, you know, serosa here you can see. It is the external lining of the anal canal, which is called serous layer. After that, it is having longitudinal muscle. Then it is having circular muscle, then submucosa, then mucosa, and in between it is having nerve supply in terms of Orbeck's plexus, here you can see, and the yellowish point that is being marked is called as Meissner's plexus. So it is very important. If we know the nerve supply, we can easily get the dimensions regarding the term of defecation. See, this is the good section in dissection where the lumen is visible, the lymphatic tissue is visible, duct of gland outside the tract we can see. Here the anal gland of mucosa we can see. Layer-wise dissection view you can visualize. Submucosa, Then glands in submucosa, these are called the anal glands. Mucosa is having actually three layers or types in it: epithelium, lamina propria, and muscularis mucosa. Then it is having veins and arteries. You have already learnt in yesterday's lecture of anatomy. Then it is comprising of mesentery, myenteric plexus, serosa, areolar connective tissue, and epithelium. Now, serosa contains areolar connective tissue and epithelium, which is responsible for the contraction of the muscle fibers as well as relaxation at the time of defecation. And circular muscle and longitudinal muscles are the both muscles in muscularis mucosa. So, this is the anatomical feature. Now, enteric nervous system, see, it is having basically two types of plexus, as I told you: myenteric plexus and submucosal plexus. So, myenteric plexus, it is conducting the signal via sensory neuron to the mucosal epithelium, and the main connection branch for this is what we can say autonomous nervous system and central nervous system. So neurons from these two nervous systems, they conduct the signal via sensory neuron to the mucosal epithelium from myenteric plexus. And in the other way, on the other way, we can see longitudinal and circular smooth muscle layers of the muscularis mucosa. They get the signals in the form of motor neurons, where submucosal plexus plays an important role for the transmission of signal or sensation of defecation. So these are two plexuses which are very important that you should keep in your mind: myenteric plexus and submucosal plexus. Now coming to the extrinsic nervous system, it is correlated with two types, that is parasympathetic and sympathetic. Now parasympathetic, it has cranial nerves and sacral nerves in it, basically S2, S3 and S4, which accelerate the movements and increases the secretions inside the anal canal. And due to these secretions, the anal canal is kept very moist, otherwise it would have been very dry and the patient would have been suffering from the pain at the time of defecation, or very dry mucosa causing a laceration, or we can say small cuts at the time of defecation. So the role of this parasympathetic nerves is very important for the moistness or moisture in the anal canal. Then sympathetic nervous system in extrinsic type, it arises from thoracic and lumbar segments of spinal cord. Ganglia and celiac and mesenteric plexuses, they inhibit movements and decreases the secretions, constrictions of sphincters. And as we say that parasympathetic and sympathetic, it goes in hand. So fight and flight mode, you have learnt it. So one increases the secretion and sympathetic decreases the secretion. So excess secretions, if they are happening, then sympathetic is having a control on that. Now, this is in short the diagrammatic view explaining the role of various types of ganglions in parasympathetic and sympathetic. So you can see from T1 to L1, T5 to L1 level, there are superior mesenteric ganglions and celiac ganglions, and below that inferior mesenteric ganglion, they are playing important role. Vagus nerve is very, very important for the stimulation of the gastrointestinal reflexes right from the esophagus till the anal canal or anus. Now, when we say the terminology of defecation, defecation, as I told you, is the final act of digestion by which organisms eliminate solid, semi-solid or liquid waste material from the digestive tract via anus. So this is very simple definition of defecation. Again, I will repeat. Defecation is a final act, final action, final process of digestion, as all of us we know. By this process, organisms, what they do, they eliminate the solid or semi-solid or liquid waste material which is coming or which is being prepared from the digestive tract via anus or through the anal part, anal opening. So this is simple definition of defecation. And humans or living human beings, they expel the feces with a frequency which varies from a few times daily, that is once a day, twice a day, few they have the frequency thrice a day also. So few times daily to a few times weekly. Many people, they are having tendency to go for defecation twice or thrice in a week. Now that is a different part, whether it is a part of any disease like constipation, that is not a topic for today. So I am here to describe only the normal physiology of defecation. But the waves of muscular contraction known as peristalsis, you know, the peristaltic movements in the walls of colon, they move or they cause to move fecal matter through the digestive tract towards the rectum. Undigested food may also be expelled in this way, in a process called egestion. Now, open defecation, the practice of defecation outside without using a toilet of any kind is still widespread in some developing countries. Now, why many people or many patients are very cautious regarding this process, that they feel if I will not pass the stool today, that means I am having some disease or I am diseased person. So this is a myth which we have to, being a doctor, we have to help them to get rid of this myth. So for that we should know the normal defecation process and normal terminology of constipation, because there are various definitions for constipation. Few say that having a tendency, not having a tendency of passing stool once a day is constipation. Many people, they told that having a tendency not passing stool for 3 days per week or thrice a week is called constipation, or more than that is called constipation. So there are number of opinions that we will come to that later on. But mainly when we see the movements of large intestine which cause the actual process of defecation, they are sluggish in nature. So mixing movements or peristalsis or hostrations, or we can see propulsive movements or mass peristalsis, these are the normal movements which differ person to person. Now it depends on that person's daily workout, that person's daily diet, that person's daily nature of his job or work, what he or she does. So depending on that, it changes. Now, there are haustrations, what we can see, which are nothing but the large circular contraction of circular muscles in the mucosa. They divide the colon into pockets called haustra. And fecal matter is getting mixed, rolled over, and then propelled with the help of these haustrations. See, the diagrammatic representation is like this. How the haustrations are there, how the fecal matter is mixed, it is rolled and then it is expelled out. So it is getting divided into tiny particles afterwards and then it is easy to expel. Then it is getting collected in the form of stool. Now mass peristalsis, we can see it is a forceful contraction. Now these people with mass peristalsis, they may have tendency to go for defecation 1 or 2 or 3 times per day. In this, it propels the feces from colon towards the anus. It is initiated after breakfast or meal, that is we can say breakfast reflux. So breakfast reflux means many people, they have a tendency when they will eat the breakfast, then only they will pass the stool or they will have a tendency of defecation. Otherwise they will get constipated. So this is a psychological phenomena as well, but it is daily habit of many persons in the society that it is getting initiated after breakfast or a meal due to the gastrocolic reflex or duodenocolic reflex. And it is lasting for 10 to 15 minutes. See, many times we see that small bachus or babies, when mother feeds that baby chapati, rice, dal or something, and after getting his or baby's meal over, the mother eats her food. While eating her food, the baby complains that I want to defecate, or the baby gets the signal of defecation or passing a stool. Immediately after 10 to 15 minutes, and many mothers, they have a tendency, ते म्हणतात अरे यार मी जेवायला बसल्यावरच ह्याला आता लागायची होती. But this is very normal and common in our society that after 10-15 minutes when it reaches the duodenum or just at the end of the stomach, the peristaltic movements, they are getting started and the forceful urge for defecation, it goes on. So defecation, we have seen the final act of digestion by which the organisms eliminate solid, semi-solid or liquid waste material from the digestive tract via anus. Now average feces quantity in normal person, it is around 80 to 200 ml per day. Now rectum remains empty most of the time. Sphincter between the rectum and sigmoid colon and sharp curvature at this junction offers resistance for filling of rectum. So this is very important to know. Now there is defecation reflex having 3 levels of action. So intrinsic level, that is myenteric defecation reflux, spinal cord parasympathetic defecation reflux, and at the level of involvement of higher centers, which starts when the rectal pressure increases to around 18 mm of Hg. So till 18 mm of Hg it is okay, but when it increases beyond that, or around, you can say, 55 mm of Hg pressure, then the actual process of expulsion of feces occurs. So this is normal defecation reflux. And now you know this is the cerebral cortex, which is passing the signal and getting the signal from the sensory nerve fibers, and there are receptors in the anal canal and mucosa which are having voluntary motor nerves to the external sphincters and involuntary motor nerves causing relaxation of bowel muscles for defecation. So external anal sphincter and internal anal sphincters, these are responsible for the defecation process. There is a pudendal nerve which is very, very important in the reflex action of this defecation process. So getting a good signal for this, I personally feel that it is mandatory to give proper toilet training since childhood to the baby, so that in early morning, जसं आयुर्वेदात आपण म्हणतो ब्राह्मी मुहूर्ते उत्तिष्ठेत जीर्णाजीर्ण समुपदेश देशन वेगान धारे अधारे जे आपलं मलमूत्र यांचं विसर्जन उत्सर्जय. So this is very important that in early morning when you visit the toilet, the cerebral cortex, it should get stimulated. For that you should train it since childhood. That is, toilet training is important, so that for whole life your body clock or biological rhythm gets disciplined for this act of defecation. This is very important. Now, intrinsic defecation reflux, that is very weak reflux. Now, stimuli responsible for distension of rectal wall by entry of feces. Receptors, they stretch the receptors in the wall of rectum. Afferent nerve fibers are the sensory fibers that terminate in myenteric plexus, and this central myenteric plexus ultimately passes the signal to the efferent nerve fibers, which are motor signals to move smooth muscles, and the result of all these refluxes is in contraction of smooth muscles of course rectum and sigmoid colon, and which is causing the relaxation of internal sphincter. Now, parasympathetic defecation reflex, same in the previous points, stimuli in the terms of distension of rectal wall by entry of feces. Receptors, there are stretch receptors in the wall of rectum, but here the afferent nerve role is from parasympathetic nerve, then comes to the spinal cord nerve, central nervous system, S2, S3, S4 level, and then passes the signal to the efferent nerve fibers, that is pelvic parasympathetic nerve, and it results in the contraction of smooth muscles of rectum and sigmoid colon, causing relaxation of internal sphincter. Okay? So these are the pathways, how the impulses from the cerebral cortex are getting passed or transmitted through the voluntary motor nerve to the external anal sphincter, and this is how the rectum or anal canal, it gets the signal for the defecation. Now, basically, internal sphincter muscles are involuntary, external muscle fibers are voluntary. So, in the defecation process, when internal sphincter relaxed, the feces, it comes down. And ultimately, it is in that person's hand whether to defecate or not in terms of external anal sphincter, because external anal sphincter is voluntary in action. So if that person is somewhere outside or in his office or job place or on the field, and he feels that he is getting an urge to defecate, but he cannot go or he cannot visit the toilet, many times it occurs. In that case, external muscle fibers, they play an important role to contract the anus and hold the feces. But it is also having the limitation. Not for whole day he can control. He has to visit the toilet, but to some extent it is having a good action unless and until whole rectum is getting filled with the feces. So this is very important to know. See, defecation reflex with higher centers. These are the few points which are very important. Deep breathe, closure of glottis, increased abdominal pressure. So these are few of the acts which are getting involved in the process of defecation. Now, adopting a squatting position or sitting position. Squatting position is mostly we can see in the Indian toilets, and sitting posture we can get in the Western toilets, that is commode. Then levator ani muscles, they get relaxed in the pelvic floor descent. Actually, squatting position is very good for easy passage of stool. When the angle is maintained from the pelvic muscles. I will come to that in next few slides. See, this is the sagittal view of anorectal area. When it is at rest, the angle is like this. See, this is a puborectalis sling which holds the anal canal. This is external anal sphincter, and inside that there is internal anal sphincter. And this is anorectal angle with anus and sigmoid colon. So normally in resting position, the angle is like this. And when during straining or during defecation, the angle increases and anorectal angle increases, and as good as it is in a straight line, in a position where the angle is increased, the puborectalis muscles, it gets relaxed, the internal anal sphincter, it gets relaxed, and the defecation occurs. So, descent of pelvic floor at the time of straining or defecation is very important in this position. Now, many entities are there where defecation process is disturbed, like anal incontinence, obstructive defecation syndrome, constipation, and diarrhea. So, up till now, we have seen the normal defecation process, normal reflux, normal nerve supply, and all that. The rectum ampulla, it stores fecal waste. Fecal waste, it is also called stool or poo before it is excreted. Now, rectum ampulla stores this fecal matter. As the waste fills the rectum, gradually, हळूहळू जसं रेक्टम भरतं किंवा फील होतं and expands the rectal walls, stretch receptors in the rectal walls, they stimulate the desire to defecate. This urge to defecate arises from the reflex contraction of rectal muscles, relaxation of the internal anal sphincter, and an initial contraction of skeletal muscle of the external anal sphincter. So if the urge is not acted upon, the material in the rectum is often returned to the colon by reverse peristalsis. म्हणून वेग धारण करू नये आपण म्हणतो. वेग धारण जर केला तर reverse peristalsis ने that material in the rectum, it is often returned to the colon again, where more water is absorbed and the feces is stored until the next mass peristaltic movement of the transverse and descending colon occurs. And in that case, that water is absorbed, so the fecal matter, it or the stool gets hard. And then the patient complains that he is suffering from hard stool, he is having pain at the time of defecation. So main cause behind that is not going to the toilet or to defecate when urge is experienced. So don't hold the urge. It is always mandatory to advise the people or patients when we deal with the anorectal practice, वेग धारण करू नका. When the rectum is full, an increase in pressure within the rectum forces apart the walls of the anal canal, allowing the fecal matter to enter the canal. And the rectum shortens as material is forced into the anal canal, and peristaltic movements, they waves push the feces out of the rectum. The internal and external anal sphincters along with the puborectalis muscle, they allow the feces to be passed away by the muscles pulling the anus up over the what we can say existing feces. I hope you can understand what I am explaining. Now coming to the continence mechanism. So when we see the normal physiology of defecation, we should also know the normal continence mechanism. Continence means having a good control over the sphincters. It is ability to control the intestinal contents till an evacuation is needed. It may be voluntary, it may be involuntary. To some extent it is involuntary. When it comes to the anus end part, then the action is voluntary. But the continence mechanism should be normal. See, this is actually the very important what we can say concept in the anorectal field, that is continence. And all these factors, they are playing important role, like internal and external anal sphincters, anorectal angle, compliance reservoir capacity, stool volume and consistency of stool, intact mental function. It also plays a very important role. If patient is mentally disturbed, then the continence is disturbed. Sensory perception neuropathways reflexes. It is also very, very important for the normal continence mechanism. Now, voluntary and involuntary control. It is very important to know the external anal sphincter is under voluntary control and internal anal sphincter is involuntary. So in infants, the defecation occurs by reflex action without the voluntary control of the external anal sphincter. And it is voluntary in adults. So young children, they learn voluntary control through the process of toilet training, as I told you. Once trained, loss of control, it is called fecal incontinence, may be caused by physical injury, nerve injury, prior surgeries like episiotomy, constipation, diarrhea, loss of storage capacity in the rectum, or loss of ganglions or villi in the rectum and anal canal. So many causes are there. Intense fright, fear, what we can say, anxiety, many mental causes are there. Inflammatory bowel disease, psychological and neurological factors, childbirth or death, many factors are there. So sometimes due to the inability to control one's bowel movement or due to excessive fear or defecation, usually accompanied by urination, it occurs involuntarily. So soiling a person's undergarments, it is not a good sign of having a control on the process of defecation. So this may cause significant embarrassment to the person or that patient if this occurs in the presence of other people or at public place. So this is very important. Now this is the diagram which I want to explain regarding the events during rectal distension. Very important. So there are three main steps in defecation: holding, straining and completion or evacuation. So puborectalis, external and internal anal sphincter, they contract. When they contract, the rectum accommodates the fecal matter. It is called holding. In Ayurveda, three valis are there: pravahani, visarjani and samvarani. So pravahani can be correlated with straining. Visarjani can be correlated with completion, and samvarani can be correlated with holding process. In straining, puborectalis, external and internal anal sphincters, they relax. When we strain, this sphincter gets relaxed, and levator and ani, they relax. When they relax, it helps the process of defecation. So this is very important. Completion, in the act of completion, external and internal anal sphincter, they relax and rectum contracts. Now, incontinence. Before that, I would like to explain regarding the importance of posture. So, what is the main importance or role in the posture of the person while defecating or while passing the stool? So that is very important to know. When we see the positions and modalities of defecation are culture dependent, the squat toilets are used by the vast majority of the world, including most of Africa, Asia and the Middle East countries. The use of sit-down toilets in the Western world is a relatively recent development, beginning in the 19th century with the advent of indoor plumbing. But the posture for the ability to control the bowel movement is very, very important. When in the squatting position, when in the sitting position, the reflex of bowel movement is differing. The comfort what you feel in the squatting positions will not be there in the sitting position. So the person will experience when he will minutely observe the difference in between these two. So, continence is the control or the normal control on the ability to defecate. Incontinence is inability to control the bowel movements, resulting in involuntary passage of stool. Now, failure of continence mechanism means the patient does not feel what he is expelling out from the anus. So, it may be gases, it may be liquid stool, it may be hard stool or semi-solid type of feces. Now, there are types of continence like we can see here, urge bowel incontinence. So, sudden need to defecate, the patient is unable to control his urge, with often fecal matter is discharged from rectum despite of the attempt to retain it. Passive incontinence or soiling, it is having experience of no sensation before leakage of stool. So, no sensation at all, and the stool is getting leaked out, and the patient is very much disturbed due to this, and he is embarrassed when it especially occurs at public places. So this is, you can see the diagrammatic representation with the normal stool perception and altered stool perception with fecal incontinence. In normal continence, it is having normal rectal compliance or relaxation of external anal sphincter, and in fecal incontinence, it is having reduced rectal compliance or low external anal sphincter and internal anal sphincter pressure, which is weakened. Now, there is a grading system for fecal incontinence, which is termed as Piscator score, which is graded in between 0 to 6. So, if the incontinence for flatus is there or mucus is there, if it is less than once a week, it is graded as 1. Then it is at least once a week, it is graded as 2. And if it is every day incontinence or for flatus or mucus, it is graded as 3 and termed as very severe terms of fecal incontinence. If it is an incontinence for liquid stool, it is termed as in terms of grade 1, grade 2, grade 3. Same, less than once a week, grade 1. At least once a week, grade 2. Every day, grade 3. And incontinence for solid stool, if it is less than once a week, it is grade 1. At least once a week, grade 2. And every day, grade 3. Now, this is AI scoring, means anal incontinence scoring. So, there are gradations for frequency and points, and it is scored in terms of 1, 2, 3, 4, 5, 6, and as the number increases, the severity also increases, and we have to opt for the higher modalities of treatment to treat this anal incontinence. Now, dyssynergic defecation is also an important phenomenon to know when we deal with the normal physiology of defecation. The coordination between the muscles that make up the pelvic floor is impaired. That is called dyssynergia. So, muscles are not working properly. The normal function of muscles is getting hampered or disturbed. Example, especially puborectalis, internal sphincter and external anal sphincter. So, these are 3 main muscles in the anal canal, and if the coordination between these 2 or 3 muscles is getting deviated or disturbed, then it is called dyssynergic defecation. Then improper contraction or relaxation of these muscle fibers during the bowel movement is also called dyssynergia. So this is an abnormal phenomenon. See, regular bowel movements, they determine the functionality and the health of the alimentary tracts in the human body. But defecation is the most common regular bowel movement which eliminates the waste from the human body. The frequency of defecation is hard to identify, which can vary from daily to weekly frequency depending on individual's bowel habits. So dyssynergic defecation, it is almost similar to chronic constipation. It is having the symptoms like abdominal bloating, excessive straining, feeling of incomplete evacuation, hard stools, less than 3 bowel movements per week, digital evacuation using fingers to assist a bowel movement. The patient has to insert his finger to evacuate the fecal matter embedded inside the anal canal. So that is also called as obstructive defecation syndrome, ODS. So it is very, very important to know when the dyssynergia of these muscle fibers it occurs. If defecation is delayed for a prolonged period, the fecal matter may harden, resulting in constipation. If defecation occurs too fast, before excess liquid is absorbed, diarrhea may occur. Other associated symptoms can include abdominal bloating, pain or distension, as I told you. Now, disorders of the bowel can seriously impact quality of life and daily activities. The causes of functional bowel disorder are multifactorial, and dietary habits such as food intolerance and low fiber diet are considered to be the primary factors for this constipation or dyssynergia. So constipation is a different topic for discussion, for which we can discuss for whole day. Number of factors are there in the constipation. So I hope that the organizers will focus on that concept also, which is very, very mandatory for anorectal surgeons to know. Now, normal defecation, fecal incontinence and dyssynergic defecation, you can see here the normal stool perception in terms of internal anal sphincter and external anal sphincter, how it looks like. In fecal incontinence, there are altered defecation factors due to reduced rectal compliance, and it is also closely related with the weak perrectal neuropathy. And dyssynergic defecation I explained you already. Just throwing a short light on the concept of constipation, also known as defecatory dysfunction. Now, it is a difficulty experienced when passing the stool. It is a failure of voiding of feces which causes discomfort due to lack of movements in the intestine. It is one of the most notable alimentary disorders, very common, that affects different age groups in the society or in the population. The common constipation is associated with abdominal distension, pain or bloating. And the most important is patient is not at all satisfied from this act of defecation. He is very much disturbed. आपण म्हणतो मनाचा आरसा हा पोटातून जातो, आणि जेव्हा पोट डिस्टर्ब असतं तेव्हा तो माणूस फ्रेश नसतो. सो इट इज व्हेरी व्हेरी closely interrelated factors with that your mental status and your bowel habits. So researchers, they revealed that the chronic constipation complied with higher risk of cardiovascular events such as coronary heart disease, ischemic stroke, while associating with an increasing risk of mortality. Besides the dietary factors, the psychological trauma or pelvic floor disorders, they can also cause the chronic constipation, and defecatory disorders also. Multiple interventions including physical activities, exercises, yoga, high fiber diet or probiotics and drug therapies. They can be widely and effectively used to treat the constipation and these defecation disorders. So this is very, very important, what we can say, phenomena. And please mind it well that constipation is a symptom, not a disease. So when you will treat any disease, you have to see whether the patient is passing normal feces or not, whether the patient is having constipation or not. If he is having constipation, then it may be an associated factor for the what we can say production of that disease. So these are number of causes of constipation like spasm of sigmoid colon, local diseases like fissure, piles, fistula, less fiber and water in diet, ignoring normal defecation reflex. It is very important cause that the patient, they ignore the normal reflex. They are having bad bowel habits due to this. Associated with other diseases like hypothyroidism, hypercalcemia, hypokalemia, etc. Dysfunction of mesenteric plexus in large intestine, megacolon. Many drugs are having direct role on the process of defecation. Decreased motility in elderly patients, depression or emotional disturbances, they are having greater role on this constipation. So this is the vicious cycle. The constipation causes anal fissure, hemorrhoids. Again, it causes constipation. So all of us, we know this. There are complications or various problems that arise due to constipation, like hemorrhoids, increased incidence of stroke and heart attacks during straining, impacted feces, that is obstructive defecation syndrome, fissure in ano, damage to the nerve due to excessive straining. Now, just a small remedy as you can all use in your OPD, in your day-to-day practice, laxatives. Now, it is of several types like bulk forming laxatives, osmotic laxatives, stimulant laxatives, fecal softeners and lubricants. So you can give or opt for any of these which is suitable for that particular person. Now these are the anal suppositories, solid dosage forms, the insertion into the body cavities or orifices. From the anus, we are supposed to insert this suppository. They melt or dissolved inside, absorbable, and exerts localized or systemic effect and help to relieve the constipation. Now coming to an Ayurvedic approach, what is being mentioned in our ancient text, as we know, is Sushruta has mentioned in Nidanstan 3 valis. Tatra sthulanta pratibaddham ardha panchangulum gudam ahuhu. Tasmin valayaha tisro. 3 types of valis. Pravahani, Visarjani, Samvarani, Cha iti. So this is very important to know the Ayurvedic aspect also, and it helps in holding, straining and completion or evacuation of the fecal matter. So together it covers or extends 4.5 angul or 4.5 angul in length and 1 angul above the anus. So this is also a well-known sutra. It is being mentioned by Sushrut Nidanstan. That is Shankhavarta Nibhashapi Upari Upari Samstitaha Gajatalu Nibhashapi Varnataha Samprakirtitaha. Now how is Gudaushtha? Romantebhyo Yavardha Ardha. So very, very nice description for the anatomy of rectum and anal canal, that is Guda. Sharir is described by Sushrutacharya. Prathamatu Gudaushtha Angula Matre. So haustrations, what is the exact look of the anal canal? Gaja Talu Nibha. Very nicely described by Sushrut. Folds are like spirals of conch, shankha म्हणतो ना, situated one above the other. Color, it resembles palate of elephant. Gaja Talu Nibha. First valley located 1 angul above the Gudoshtha. And Gudoshtha is the area of 1.5 yava above the lines of hair. So for good defecation, see, the ending open defecation is an indicator being used to measure progress towards the sustainable development, or extreme, we can say, the importance. The anus and rectum may be cleansed after defecation. It should be kept very clean with either toilet paper or we can say proper spraying or watering. So similar absorbent material, or what we can say, one of the tradition. Now country to country it differs, but the thing is, it is always dependent on how you maintain the hygiene of that area, and it is good to avoid the production of or the occurrence of the various diseases at that point. And it is always beneficial to have good dietary habits, ज्याला आपण आहार आणि विहार असं म्हणतो. For good defecation, you should advise all your patients for these types of habits. You should advise your patient to take good diet. You should tell them to eat more fiber, more beans, whole grains, cereals, fresh fruits, vegetables, especially high fiber diet. And it is also beneficial to take probiotics regularly, as they promote healthy bacteria in gut, which is beneficial. Exercise and yoga also, it plays a very, very important role. These are few of the asanas like Vajrasan, Pavanamuktasan, Bhujangasan, so Padahastasana. So they are beneficial to improve your bowel movements. And the best exercise that I always tell my patient in my OPD की रोजचे 12 सूर्य नमस्कार घाला, तुम्हाला कुठलाही औषधाची गरज भासणार नाही. Drink plenty adequate water, take proper diet, do proper exercise and yoga, maintain your mental and physical status good. So liquid helps to keep the stool soft, no doubt. Avoid the junk food, of course, hard drinks, even tea and coffee. So to summarize, you can see, I have already explained. Drink more water, eat healthy diet, do exercises or yoga, don't control natural urges, avoid junk foods, spicy foods, hard drinks, smoking, addictions like alcohols and all that. So if you will advise your patients with keeping all these good aspects in mind, I am sure that the society will get a help from all of us being a doctor to get rid of all these diseases like constipation, irritable bowel syndrome, dyssynergic defecation, obstructive defecation syndrome and all that. And actual physiology of defecation, if all of us we know, being an anorectal surgeon, or when you will practice anorectal in the anorectal clinic, it is very mandatory. It is very, very necessary to know the normal physiology of defecation so that you can direct and advise very nicely and properly in a good way to your patients. No doubt. So, thank you so much. I am again extending my hearty thanks on regards to the organizers for giving me the opportunity to express my views. I hope it is clear to you all. If you have any queries, you can ask. Thank you.
Thank you very much, madam. Thank you again for a very nice and elaborate presentation related to physiology of anal canal, its clinical importance and practical application. It is always a pleasure to have you on our dais every time, and hoping to see you again many times again. Thank you very much. I will request delegates, if they have any questions, to put them in the chat box. Madam, we'll wait for 2 minutes.
Okay, no doubt. I think many of the doctors here are practicing anorectal, or if they are not, then I would like to advise or tell them that it is very safe and good practice. So if you are clear with the basic concept of anus and rectum, then it is always good to, you can earn a lot through this.
Yes, madam, there are questions in the chat box. Can you access them?
Just a minute, yeah. Treatment of dyssynergic defecation. Okay. Actually, see, dyssynergic defecation is a process where the muscles are not working good. So we have to train these muscles properly, and you have to advise that particular patient to go for pelvic floor exercises. So actually, constipation, you have to just ask or take proper history whether that patient is having constipation, whether that patient is suffering from psychological distress or any other associated disease or pathology. And if it is there, you have to rule out that pathology and then you have to treat accordingly. You have to examine the patient for anorectal manometry, or you have to take the pressure, anal pressure, and you have to go for balloon expulsion test, and accordingly you have to treat that the cause of dyssynergic defecation. So going for anal manometry is one of the diagnostic criteria to evaluate the dyssynergic defecation, and after getting the score of that dyssynergia, you have to treat the patient. Now the treatment should be customized for each individual, so it will differ from person to person. So taking into consideration patient symptoms, underlying pathology, age, comorbid factors, patient's concerns and expectations. So it consists of standard treatment of constipation. So you have to advise good laxative to that particular patient, or you have to train that patient for biofeedback therapy and other measures, including many use botulinum toxins, injection therapy, or they opt for myectomy or ileostomy as well. If dyssynergia is of very severe type, in that case we have to opt for the surgery also, and this should consist of a detailed clinical assessment and correction of coexisting issues such as avoiding constipation, constipating medication or adequate fiber and fluid intake, regular exercise. Mainly the lifestyle modification will get rid of this dyssynergia. So in 90% patients I have seen, if you will modify the lifestyle, in that case you can capitalize or improve this mechanism and stimulate the colon in a good manner. Then most of the pediatric cases suffer from constipation, very dry and hard stool even after plenty of water. Any suggestions? See, in pediatric cases, when small kids they come to us, I personally ask their parents that they are giving milk to him. So many kids are having what we can say milk intolerance. So due to milk, they are constipated. So immediately when we stop the milk, because the milk which we get in this era, it is of not having good quality. We cannot challenge की ताजं ताजं गाईचं म्हशीचं दूध काढल्या काढल्या आपण त्याला देतोय. So we cannot have an authentic source of that milk. So pasteurization, chemical, what we can say mixing and preservatives, lots of things in that milk. So that intolerance may be there, which will cause or which may cause the constipation in the kids. So this is very important factor. And other one is avoid junk food, because many of the kids they are fond of vada pav, Maggi, pizza, burger, and parents are giving it to them. So don't entertain, force them to eat healthy food which is being prepared at home, which is fresh. Any dietary advice for chronic constipation? Chronic constipation, see, not only diet will act for to treat this chronic constipation. Exercise, lifestyle modification will also play an important role. Now, fiber accelerates the colonic transit and bulk the stool either by drawing fluid to colonic lumen or by facilitating fermentation and affecting gut microbiota or epithelial permeability. But a systemic review on the effect of fibers in chronic constipation, it is showing that fiber is beneficial for mild to moderate constipation. And constipation showed, which is predominant IBS, for IBS, that is irritable bowel syndrome. It improved global symptoms, decreased straining, increased stool frequency, softened stool consistency, and decreased laxative usage. So although most of the studies used soluble fibers such as what we can say lactitol, lactulose, or we can say psyllium, there is limited evidence that insoluble fibers such as calcium polycarbophil or methyl cellulose, what we use in daily practice. So both soluble and insoluble fibers as well as natural dietary fibers such as green vegetable, leafy vegetables are effective. So it is important to recommend patients to take adequate water intake while taking fibers to avoid hard and bulky stools as well. Isabgol is always a good bulky agent to overcome this constipation. Now, how to treat IBS? See, IBS is a very vast topic. We will keep another lecture on IBS, irritable bowel syndrome. It is having number of symptoms. It is having Crohn's disease or ulcerative colitis. So, depending on the etiological factors and pathological factors, we have to treat that patient according to it. So there is not a standard treatment for IBS, that this is a patient of IBS and this is a standard protocol of treatment for IBS. So it is having number of what we can say angles to see towards that disease. What are the pelvic floor exercises? I am having a good video of that pelvic floor exercises, but unfortunately it is in my hard disk. I will forward it to the organizers and they can send it to the group or personally. If you can, if you want, you can contact me also personally. I will send you the video of how the exercise of pelvic floor muscles is to be done. So it is very important. Basti is useful for it in small amount of for pediatric. Basti is always good, no doubt. Matra Basti is always beneficial for chronic constipation. 60 ml 80 ml एवढी जरी तुम्ही साध्या तिळतेलाची कोष्ण तिळतेलाची मात्रा बस्ती दिली तरी सुद्धा फायदा होतो पेशंट्सना. I am not in an opinion to advise patients to take laxatives for constipation because they get a habit, and even for one day if they will not take that, the psychology tells that they will not pass the stool. So I force to recommend the lifestyle modifications, exercises, proper diet, proper yoga, proper food habits, proper work habits at their workplace, and if at all they are suffering from the constipation, then I advise very household simple remedies like kale manuke, black resin, anjeer, or take good amount of ghee, or erendel tel. Castor oil is very good for the chronic constipation, especially in elderly persons. So castor oil, if you will advise them to take even after on an alternate day or thrice a week, it is always beneficial for them, and they will not get the habit to have it or to take it daily. Nitya Mrudu Virechan with Erendel Tel. Yeah, I just answered it. Can give. Yeah. Please give us mobile number. You can take it from the organizers, or should I? Okay, I will enter my mobile number in the chat box. 939867. Yeah. So, in case of any doubt or query, you can always contact to me. We conduct 1 month eye care courses for Kshar Sutra at our institute, where we give the knowledge of whole anorectal field, starting from anatomy and physiology up to the treatment of all these anorectal disorders, basic disorders like pile fissure, fistula, and all that. And even this Dr. Rushikesh, Dr. Mangesh, this Shreyas E-Learning Academy, all these, they are taking good efforts for giving the knowledge of this anorectal field to all the doctors. And basic things, see, we don't expect you to operate. Even if you can diagnose the entity without fail correctly, at least you can refer that particular patient to a proper person. So even if you do that, it is good at your level, being a general practitioner. So for that, you should be clear in the concepts of anatomy and physiology, or basic concepts should be clear. So I think I have answered all the questions. So anything else?
Yes, thank you very much, madam, for taking out time and answering all the queries. I am sure all the delegates will be benefited with the practical knowledge that you shared. And I hope everyone will be interested to have their hand over the anorectal practice after listening this lecture. Thank you again very much from Shreyas e-learning team. And we hope to see you on the dais very soon in our upcoming seminars as well.
Sure. Anytime. Thank you so much.
Thank you very much.
Yeah. All the best to all.
Thank you. Yes, I hereby declare that the meeting today is over. We'll meet for the next session tomorrow. Thank you.
चावल तो पूरा एक पतला रखा हुआ है। सब्जी कौन सा खाएगा? पेट पर दिया बहुत चावल किसी थाली में बांध थाली में बांध वाला दवाई नहीं होता है चलने के दिन खाती हो लेकिन बात नहीं होता
वो बात दवाई की जगह हम चाहिए तो बच्चा था और इतना रात होता था जब हमारा सिर
दिन कर्मचारी अभी नहीं होता जब कोरोना के टाइम था जो खा रहा खांसी बढ़ा था
तीन चार सिरप हमेशा पका रखते थे घर में 4 सिरप मुंह वाला था चंदन जी का 2 बच्चे थे 4 सिरप मॉक्स बेटनीसोल आस्पालिन क्रोसिन 4 सिरप हम समय घर में था ये तो कुछ छोड़ा
तो शादी के आगे खाने सारे सब फेल गए तो शादी के आगे खाने सब फेल गए
जहाँ हम जाते थे तो दवाई रखते रहते थे चेक करते थे तो दवाई कम नहीं रखता तो दोबारा कहाँ से दवाई मिलेगा 3-4 दवाई से सब बच्चे दवा करेंगे उसके बाद हमेशा सांस फूलता है हर रास्ता में करते रहते थे हमेशा हमें आना चाहिए
जलेबी खाना स्टार्ट कर चला काट के पड़ता किसका कब है नर्स बनेगी
उसका पेपर है तो दूंगा नहीं क्या उसका भी
कितना फॉर्म भरे थे उसका
उसको पता नहीं
फॉर्म कितने भरी थी
मेरी दोस्त ने पहले तो उसको देना है अभी
कितने में दिया था 1500 से कम तो होगा नहीं कोई एंट्रेंस एग्जाम 900 रुपये एंट्रेंस दे दिया हमें बना रही है 900 रुपये में एंट्रेंस दे रही है 2000 से कम का नहीं होगा फॉर्म नर्सिंग का इतना मैं गारंटी दे रहा हूँ
नेट का 1500 का और नर्सिंग का वो इसको क्यों निकाले हो खराब करोगी क्या
फिर मुंह में डालता हूँ की करता हूँ नहीं करता हूँ तो आराम है क्लीन करवाऊंगा एक बार क्लीन करवाते हैं बहुत टाइम मम्मी कर रहा हूँ स्टॉक मार्केटिंग स्टार्ट एक बार पहले जाऊँगा ठंडे वाली घूमने
कल चले अरे मंदिर जा रहे हैं
ठंडे में चलने का पक्का चलने पढ़ाई लिखाई का मैं इतना टेंशन नहीं लूँगा होगा पढ़ाई लिखाई का इतना टेंशन नहीं लूँगा
हम बड़े हनुमान मंदिर से ना बचपन में जाते थे कितनी बार हर मंगलवार को जाते थे ना आप में पापा है मम्मी हर मंगलवार को कि हर एक हफ्ते पे कितने दिन पे जाते थे नहीं यार बहुत बार जा चुके हैं वहाँ पे तो बड़े हनुमान मंदिर चलेगा
सब चलते चलेंगे पहले एक वीडियो तो देख लेगा
मैं देख लूंगा मैं रात में देख लूंगा
सीख ले स्टार्टिंग चलिए टेक्निकल अंग्रेजी सीख लेगी ना स्टार्टिंग कर लेता हूँ जैसे कुंडली होती है ना वो
ओए ओए ऐसा
ये
तो
कुंडली है जो
थोड़ी सी बोल दे दूँ सारी कॉपी